Move on from hypercapnia to blood glucose control. So we've got Alex Poole is going to talk to us, and he's a project manager at the University of Adelaide and Donor Life, SA, and critical care nurse and PhD candidate in the University of Adelaide. And he's going to talk about the LUCID Study. Thank you, Alex.
Great, thanks. I'd like to obviously thank the conveners for giving me the opportunity to speak. And today I'm going to talk about glucose control in critically ill patients, with a particular focus, I suppose, in type 2 diabetic patients. And then I'm going to talk a little bit about the LUCID study, which we're currently doing. I'd like to thank the management committee for this study, because this work wouldn't be able to be done without their contribution. So LUCID is showing the ability to think clearly, especially in intervals between periods of confusion or insanity. And it probably somewhat sums up the experience of an ICU patient, I think. So I'm going to give a bit of a background information on glycemia and the critically ill population in general. I'm then going to talk about the relevance of type 2 diabetic patients, some preliminary data that's been published in type 2 diabetic patients, and then I'm going to move on and talk about the phase 2 study and the longer term objectives of this body of work. So why are we interested in blood glucose control? Well, as you're probably aware, hyperglycemia is in critical illness is pretty much ubiquitous. So much so that during critical illness, around 30 to 40% of patients experience hyperglycemia at some point. Because this condition is so common, there's been many investigations and many studies done over a long period of time. And the landmark Leuven study, published in the New England Journal of Medicine in 2001, showed a significant improvement in survival in both ICU and hospital. And it really led to a paradigm shift in the approach to management of glycemia in critical illness. But this single centre study in a surgical ICU had some inherent design problems and flaws and was ceased early due to benefit. Given this perceived benefit and the design limitations of this study, it really led to another trial, or several trials. But the main one of these was the Nice Sugar trial, which again was published in the New England Journal of Medicine. And this study was of 6,000 patients, and it compared intensive glucose therapy of 4.5 to 6 to standard, which is 6 to 10, with its primary endpoint being 90-day mortality. And as we can see here, the intensive glucose control increased 90-day mortality. So what did we learn? Protocols can be immensely helpful in standardising practice, but can lead to significant harm if they're misaligned. And based on the results of the Nice Sugar study, the adoption of intensive glucose control was most likely harmful. And in the US alone, it may have led to up to 26,000 deaths per year. So what do the current guidelines tell us? Well, the American Diabetes Association and Society for Critical Care Medicine suggest that we maintain blood glucose levels below 10 millimoles, which is consistent with that of the largest trial to date. So what we decided to do was survey Australian intensive care intensivists on their current practice and how they manage type 2 diabetic patients. And in this survey we found that the predominant practice was to keep blood glucose levels below 10 and maintain between 6 and 10, which is consistent with Nice Sugar. And this is usually done by the administration of intravenous insulin. But the respondents did feel that there was still some uncertainty on how to best manage type 2 diabetic patients, and we felt there was some level of equipoise to conduct a randomised control trial. So over a recent time, a number of studies have explored the management of hypoglycemia in diabetics admitted to ICU. The problem with the current guidelines that we see is that they do not discriminate between patients. So they treat them all the same, regardless of whether they have underlying type 2 diabetes or they don't have diabetes at all. But as we know, our bodies adapt to these conditions, and type 2 diabetic patients' bodies probably adapt to the hyperglycemia that they run around in the community with. So what's the prevalence? Well, in 2012, around 12% of the Australian population had diabetes. And as one might expect, the percentage of patients in hospital with type 2 diabetes is slightly higher. So around 11 to 35% of patients admitted to hospital have diabetes. And in the ICU, when we look at that population, it's even higher. So between 12 to 40% of patients admitted to ICU have type 2 diabetes. And if we extrapolate this out, it translates to around 30,000 patients admitted to Australian ICUs with diabetes. So this population is prevalent and probably has a different need than non-diabetic patients when it comes to glycemic management. And the global outlook is somewhat similar, with the population anticipated to grow to over 440 million people living with type 2 diabetes, well, predominantly living with type 2 diabetes. It also presents a significant cost burden to our health system, which is expected to reach around $500 billion per year. So the potential mechanism. Type 2 diabetics' bodies adapt to chronic hyperglycemia. We know that hypoglycemia is associated with poor outcomes. Recurrent is worse. There is a suggestion that relative hypoglycemia is harmful. A relative hypoglycemia is when a person's baseline glycemia is elevated, and thus if we lower them down to a normal level of glycemia, they have hypoglycemic effects. So they've essentially shifted their normal, so their normal is slightly higher. There is also thought that glycemic variability is harmful. So over recent time, there have been a number of exploratory sort of studies on the management of type 2 diabetic patients. So in 2011, in a retrospective observational study of 450 ICU patients with type 2 diabetes, done by EGGI, had HbA1cs measured and found an interaction between pre-existing hyperglycemia, so HbA1c greater than 7, and acute glycemia and mortality. These observations generate the hypothesis that the glucose levels that are considered safe and desirable in non-diabetics might be undesirable in diabetic patients. Then in 2014, Plummer, in a prospective cohort study, found that in 1,000 consecutively admitted ICU patients with significant, insufficiently controlled diabetes, so HbA1c greater than 7 again, there was no significant relationship between mortality and acute glycemia. So as we can see here, the purple, as the peak blood glucose levels raise, mortality was not changed. So our diabetic patients from this data looks like they tolerate hyperglycemia better than non-diabetics. So if we have a look at some other data, so Vandenberg did a post hoc analysis of the first study in 2006. And in this post hoc analysis, they show that diabetic patients had no significant mortality benefit for tight glycemic control. And then some prospective interventional studies by Demuso, Carr and Luethi in 2018 showed that liberal blood glucose control in ICU in type 2 diabetic patients was safe. So this preliminary data suggests that it's worthwhile and safe to undertake a larger randomised control trial. But we need more data to support this and obtain funding to complete such a study, and hence the LUCID Phase 2 study. The primary aim of this study is to attenuate moderate to severe hypoglycemia, moderate being less than 3.9 millimoles, and severe being less than 2.2. And secondary aims are to attenuate relative hypoglycemia, recurrent hypos, and diminish that glycemic variability. Our target population for this studies are adult patients that will be in the ICU until the day after tomorrow, have an arterial line or central line in situ, have diabetes, a reasonable likelihood that their blood glucose levels will raise above 10. We're excluding patients where death is inevitable, those that are admitted with diabetic ketoacidosis or other hyperosmolar states. We're excluding type 1 diabetics. We're excluding those that require specific blood glucose targets, those that will be eating within 24 hours, and those that have been in the ICU or an ICU for greater than 24 hours, and those with pregnancy. So the intervention group of this study will have insulin commence when their blood glucose is raised above 14 and maintained between 10 to 14. The standard arm will have their blood glucose commenced when it goes above 10 and maintained between 6 and 10. And this will continue out until day 14. So being a phase 2 feasibility study, we've got some process outcomes, which are recruitment rate, consent withdrawal rate, because we have approval for delayed consent, protocol adherence, treatment separation. We're looking at point of care HbA1c test measurements and insulin requirements. The scientific outcomes are hypoglycemia, number and severity, relative hypoglycemia, the glycemic variability, and time-weighted mean glucose. Our exploratory endpoints are 90-day mortality, 28-day ICU-free days, signal for harm with regards to infection, weakness, and feed intolerance. The power calculation for this study is based on the data from the Nice Sugar trial and Palashkar study, and we've been given an ethics approval to look at 450 patients. So the progress of LUCID to date. We've obtained ethics approval. We've got funding, thankfully, from the Royal Adelaide Hospital, Diabetes Australia, the Intensive Care Foundation, and most recently the Melbourne Academic Centre for Health. We've developed an electronic case report form. We've got web-based randomisation, and recruitment commenced in May 2017. We've currently got 10 centres recruiting for the study all around Australia. We've got a further 7 to commence, and we'll hopefully have New Zealand on board shortly. We've currently got 194 as of this morning. So thanks very much to the Western Hospital if there's anyone here. And we are hopeful and crossing our fingers that we're going to complete by May 2019. So what are our longer term objectives? We'll hope that LUCID at a minimum will inform current practice, provide feasibility information for a larger RCT, and further inform the safety and tolerability of a liberal blood glucose approach to the management of type 2 diabetic patients. But ultimately, a definitive phase 3 open label parallel group RCT comparing liberal blood glucose targets and standard care in critically ill patients with pre-existing type 2 diabetes is the aim, with the primary endpoint of 90-day mortality. So thanks very much. I'd just like to say that we are seeking additional sites for the study, and with that recent additional grant, the per patient payments have increased significantly, and they will now be $500. And it's a very modest CRF because it was commenced when it was a love job. So please contact me if you're interested.
Is there any questions for Alex on the LUCID study? Just talk into the microphone, please. Thanks.
Just want to ask you about 2 questions. One is, you say glycemic variability. Are you using one method of measurement? Because there are too many variables when you measure with finger prick or arterial gas.
Yeah, so we can't really, with a pragmatic sort of study like this, we can't really dictate how people measure and we've had to go with what the clinical approach is in general. We are collecting the information on the method that has been used to take that measurement, and we're only collecting blood glucoses at set level at certain times. So we're not collecting every single blood glucose that is recorded for that patient, simply because we needed to keep that CRF as small as possible when we didn't really have any money.
Because one of your data sets are going to be variability of the glucose.
Yes.
So there will be a lot of variability in variable measurements.
Yeah.
But they're recommending nowadays continuous glucose monitoring.
Yes.
Have you considered that in your study?
Yeah, so I'm actually going to be doing a nested cohort study with this and doing continuous glucose monitoring in a group of patients at the Royal Adelaide Hospital.
Yeah.
And so therefore I hope that we'll get a bit of fidelity in some of those, and a smaller group of patients. But it just wasn't feasible to have that level of data for every single patient that's enrolled in the study at this stage. But, maybe that's something that we will consider, I suppose, for that next phase if this does lead us somewhere.
And in your exclusion criteria, what is the basis for 24 hours instead of 12 hours? Are you not going to miss some of the patients if you put 24 hours?
If they've been in ICU for 24
fasting.
hours?
I'm talking about fasting. If they're taking food 24 hours before.
After 24 hours. Yeah, so we felt that was kind of, those patients are probably the ones that are going to be discharged from the ICU shortly after admission. So we're after patients that are likely to be in ICU for a number of days. We don't think that there would be an effect in patients that are in ICU for 24 hours. So your simple cardiothoracic surgical patient that's in there for 24, 48 hours maybe, and then is gone. We don't think that they will benefit.
Thank you.
Thanks very much. 2 quick questions. Is this a non-inferiority study, so it's just a one-tailed test?
Yes.
And the next question is, are you going to specify the algorithm for your glycemic control?
No, so that we are specifying the time that what point that they commence insulin, and then the target range that we want them to maintain. But what we wanted was consistency in the protocols which the institutions were using. So I suppose some institutions are going to measure their blood glucoses every hour, some will measure them 2 hourly, and so we wanted consistency at the centres, so because otherwise you're measuring kind of 2 different things, and we needed a pragmatic approach that we could kind of implement in all the hospitals, and we didn't think that we would get centres on board if they had to change both of their protocols, basically, because everyone's got little nuances, I suppose, in their protocols, but we are collecting, obviously, every single protocol that's being used in the study.
Any more questions?
I think we've got it covered there. So I think we're here. Thank you.